Hi everyone, this is Tim, your Block 2 lecture instructor, and this PowerPoint is going to cover acid and bases. I know this is going to be not necessarily a harder chapter to learn, but I know you guys are going to have a lot of questions, so definitely write things down as we go through this PowerPoint. Bring your questions to class. I'm going to spend some time in class going over these things and going over what normal blood gas levels are and how to interpret them. So it's a pretty simple PowerPoint, but I'm going to try and make it as simple as possible, but definitely bring your questions to class. All right, so acids. Acids are produced as end products of metabolism. Acids contain hydrogen ions. Acids are hydrogen donors in order to form a weaker base. The strength of the acid is determined by the number of hydrogen ions it contains. Now, I'm not expecting you to learn cellular levels. I'm not expecting you to go back to your chemistry class and figure this all out. But I think if you kind of get a basic understanding of how these work, it'll all add up. And like I said, when you get to ABGs and normal blood gases, it'll make perfect sense. So keep that in mind. So bases contain no hydrogen ions. Bases are hydrogen acceptors from acids, and this can either strengthen a base or weaken an acid. So the buffers, these are the middlemen. They keep the pH within normal range. They absorb or release hydrogen ions as needed. The primary buffering system is extracellular fluid. This is hemoglobin system. Red blood cells and chloride shifts in and out in response to the amount of O2. Plasma protein system works with the liver to attract or release hydrogen ions. So remember, lungs control the O2 and the CO2 levels, and the kidneys control bicarbonate levels, and phosphate helps the kidneys. So kind of keep that in mind. So with the lungs, second buffering system to maintain acid-base balance. In acidosis, respiratory rate and depth increase in order to exhale acids, or CO2, which decreases acids. In alkalosis, respiratory rate and depth decrease. CO2 is retained and acid increases. The lungs can correct acid-base problems in about 10 to 30 seconds. So with the lungs, if you would sit and actually inhale and exhale, you have a balance. If your respiratory rate and depth increase, which means that you're increasing the amount of O2 that you're inhaling in order to maintain homeostasis, you will exhale the same amount of CO2. If, for whatever reason, your respiratory rate and depth increase, but your exhalation is not increased, then you actually have a buildup of CO2. In alkalosis, same thing. Respiratory rate decrease, CO2 is retained, and acid increases. So with the kidneys, the ultimate in correcting acid-base problems, but can take hours or days to actually fix. So in acidosis, excess hydrogen ions are secreted into the tubules and excreted into the urine. In alkalosis, pH increases, excess bicarbonate ions move into the tubules and combine with sodium and excreted into the urine. So for potassium, potassium and hydrogen move in and out of cells, and in acidosis, hydrogen ions are moving into the cells and potassium moves out, increasing potassium levels, decreasing the acidity. In alkalosis, hydrogen ions move out of the cell, potassium moves in, decreasing potassium levels, increasing acidity. So with respiratory acidosis, it's caused by primary defects in function of the lungs or changes in normal respiration patterns. Obstruction of airway or respiratory system depression. The causes could be asthma, which is pulmonary edema, atelectasis, pneumonia, bronchial ectasis, pulmonary embolisms, emphysema, brain traumas, hypoventilation, or central nervous system depression. So interventions. You're going to monitor for signs of respiratory distress. You're going to administer O2, place your patient in high Fowlers, respiratory treatments or SVN treatments, encourage hydration, suction the airway, Patient will be anxious, which obviously they feel like they're suffocating. You're going to improve ventilation, and by doing so, you're not going to administer drugs. Morphine, Dilaudid, things that actually will decrease or depress the respirations is not going to help. You can monitor electrolytes, administer antibiotics, and can prepare for intubation. Because if they're not breathing well, they're not going to be able to do that for very long, and they may have to be intubated. So respiratory alkalosis, accumulation of base or from loss of acid. It's overstimulation of the respiratory system. So it could be fever, hyperventilation, hypoxia, hysteria, overventilation, or pain. Interventions, you're going to monitor for signs of respiratory distress, provide emotional support so you can help kind of calm them down, teach them breathing treatments, have them count with you every time they breathe so they're able to actually bring those respirations down and not breathe as hard and as fast and as quickly. Provide rebreathing masks so they're able to actually breathe back in the CO2. You're going to monitor vented patients. You're going to monitor labs such as the potassium and the calcium, and possible potassium gluconate can actually be administered. So for metabolic acidosis, it's the loss of too much base and or retention of too much acid. Causes could be diabetes mellitus or diabetic ketoacidosis. This is not enough insulin. It leads to excessive accumulation of ketones and acids and bicarbonate being depleted. So too much aspirin, a high-fat diet, insufficient metabolism of carbs, renal insufficiency, or severe diarrhea, because severe diarrhea actually lowers the potassium. So interventions, you're going to monitor for signs of respiratory distress. You're going to assess level of consciousness. You're going to monitor ins and outs. You're going to replace their electrolytes. You're going to put your patient on seizure precautions. You're going to monitor for serum potassium levels, and they may need dialysis. Metabolic acidosis is deficient of carbonic acid. It's accumulation of base or from a loss of acid. Causes could be from diuretics, excessive vomiting or gastric suctioning, hyperaldosteronism, ingestion or infusion of sodium bicarb, or mass transfusion of whole blood. Large amounts of anticoagulants metabolized to bicarbonate. Interventions are going to be monitored for signs of respiratory distress, monitor potassium and calcium levels, medications to excrete bicarb, and you're going to actually replace the potassium chloride. And that's it. It's probably as clear as mud. I went through it pretty quickly. I want you to read the book, compare it to the actual PowerPoint, try to make some sense of it. Like I said, don't narrow it down all the way to the chemical or the level to where it's the cellular level, because that's just way too much. I want you to be able to understand that if one is too high, the other one is going to be too low, which is going to be your acid and your bases. If it's affecting the respiratory system, then we know it's respiratory problems, and if it's not, it's going to be a metabolic, which is a kidney issue. So kind of keep those in mind. And again, bring your questions to class, and we'll definitely make it much simpler.